RHA recognizes that it sits on the ancestral homeland of the Kumeyaay Nation. RHA extends its respect and gratitude to the Kumeyaay people who have lived here since time immemorial. I'm grateful for every person here and the ancestors of everyone in this room and virtual room for participating. I know sometimes it can feel like a performance to say like our respects for the land acknowledgement, but I do believe in land back, meaning returning stewardship to the people who are the rightful stewards of this land. And we are just visitors here, essentially. So, sorry, guys. Okay. So we're going to discuss a complex case. The slides will be in Spanish, so you can read them all, but I'll be talking about it in English. This is about a Haitian woman, about 33 years old. She presented from Haiti. She has family in Haiti, but they have not been helpful to her or taking care of her. She's also widowed. She has two children who are girls, ages 10 and 4. And she was referred to Refugee Health Alliance by a shelter for having psychotic episodes or psychotic crises, wherein she was calling herself disgusting and calling herself dirty and saying that she did not deserve to live. She didn't want to go on, but she said her daughters were her protective factor. So these are kind of like the list of symptoms that we all were able to elicit from the mom. Basically, she complained of repeated panic attacks, anxiety, overwhelming fears. They were intrusive, a feeling of being out of control, or feeling like the sense of impending doom, like during a panic attack. She would relive traumatic situations over and over again in her thoughts, and it would play out. She would have nightmares. She would have trouble sleeping. She would have really difficult, like kind of overwhelming feelings anytime she did have traumatic memories kind of come back to her. She had appetite disturbances. She would really overvalue this sense of like culpability, this sense of guilt and worthlessness. She complained of being very isolated, not being able to enjoy anything. She also complained of hallucinations, which were auditory. They were what we consider ego-syntonic, meaning they fall in line with how she was feeling, what her mood was, the quality of the hallucinations. So for non-medical folks, it's really just ends up being voices telling you how terrible you are in lots of very specific ways, or general ways. And she would also have suicidal thoughts, but they were passive. She had no access or means or drugs or any ways to kind of harm herself. She was blind. She was in a strange city. She was Black. And she had 2 young daughters. So this is like a breakdown of history for this patient. So psychosocial, she came to Tijuana like about a month prior to her first interaction with us, staying at a shelter, which is quite far away. She had the two girls that I brought up, and she was trying to get to the United States. She had friends there who were going to kind of support her, but she had taken like this long journey. And several, kind of what Sean brought up, there's pre-migration trauma, there's during migration trauma, and then there's post-migration trauma. And she definitely had experiences that I won't really go into because it's not exactly important to like the case. But she did have a history of social and family violence. She suffered economic, sexual, and psychological abuse, specifically more during her childhood. She denies no substance use history. Regarding medical history, it was unclear like her amount of access to medical care, but she said as an infant, she had a fever, which led to her being blind, but she denies any other instances of seizures or physically traumatic experiences. And psychiatric history included 3 prior hospitalizations for major depressive disorder, severe with psychotic features. She denies prior suicide attempts or self-harm. And again, her children are her protective factors. So this is the mental status exam. So what is it? En espera.
I shut down.
No. I love that you're the tech person. You can't operate WhatsApp, but it's okay. So for the mental status exam, we have a blind woman. She's alert and she's oriented. It's not like she's confused. She was cooperative with the questioning on my first exam with her. Her speech was adequate, spontaneous, congruent, linear. Things that did kind of come up on the mental status exam are overvalued ideas of like really focusing on her handicap or her disability, being blind, as like a big barrier and affecting her sense of worth. And then the intrusive like suicidal ideation. She reported herself as having a lot of anxiety and depression. Her affect was restrictive. And then again, she complained of auditory hallucinations. But concentration was there. There was some issues with her like sense of reality. And she was only partially oriented to the future. It was hard for her to figure out what the next steps were. So these are our course of illness. So these are the different interactions that we had with this patient on a very short amount of time. So first interaction was actually with our in-person psychiatrist. We have Dr. Zuniga, who comes in twice a month for like an afternoon and sees patients. And she first was referred to us and Jennifer saw her. I think at that time she had said like, oh, these were the meds I was on, some of which we couldn't like continue because they're scheduled class 2 drugs. And so, but she had been off of them for like a while. She'd been off of benzodiazepines for a while. And so we used what we had on hand, just Benadryl for bedtime to help her sleep, risperidone 2 milligrams twice a day, and then the Zoloft 15 milligrams. So a month later, there's an emergency consult that kind of comes through from the shelter where she's staying. And she said that she had stopped taking her medications because the Benadryl had made her too sleepy and she needed to take care of her children. Being someone who's blind, having like also your alertness compromised was an extra barrier she was really unable to like manage, or at least she felt really worried about it. And so at that time, the shelter was reporting that it was like a crisis and she received, I think we gave her like a olanzapine one-time dose just to like help her sleep and just to kind of address the situation that day. We started her back on her medications. We gave her propranolol to help with panic as well. In terms of administration, we asked staff who were actually really great at the shelter, with whom we ended up communicating quite a bit, to administer propranolol twice a day. I checked on her the next day and she developed like a nosebleed and that like freaked her out. She couldn't that was another thing. It didn't really like nothing happened. It was like easily resolved, but it sounded like towards the end of the day, everything would get worse. And that's when things get quiet. Like end of the day for a lot of patients is particularly difficult because they don't have distractions. They can't move their body. They have a lot of restless energy. A lot of the trauma that's impacting them physically gets stored in their body and they have nowhere to put that. So when things slow down is when memories come up and sensations come up again, and it's particularly difficult for them to manage nighttime. So basically, even though she was at the shelter that was quite far away, I was able to, with the help of the staff, we would just do like video visits, and I would be able to see her countenance and see how she was doing. But she would kind of present like kind of more chilled out to me, but at the end of the day, she would kind of like the staff and the families there. Staff go home. It's just the families there. There's really not staff sometimes at night. The families just take care of themselves. And so, you know, she would say like, I want to leave the shelter, but nobody would want, because she created such a scene at night. She would be described as like going into a delirium, yelling things and like shaking. So I increased her risperidone to twice a day. But by day 4, like the 27th of September, the shelter themselves decided that they would pony up the money to basically hospitalize her. And that meant that the kids would be unaccompanied during her hospitalization. To receive a hospitalization, you have to pay for the entire week's worth of days. You can't just go in as much as you need and come out. You pay for the week, and that's what you get. And if you need more weeks, then you pay for more weeks. And usually you need someone to co-sign you going in there, like a family member. In this case, I don't know, they accepted us. And so basically the shelter staff transported her to Mexicali, and she was admitted there for 1 week. On the 28th, on the day after she was hospitalized, the shelter staff reached out to us again because they were worried about the children now, the girls. And our wonderful psychologist, Diana, provided psychoeducation about the situation and started kind of coordinating efforts to try and help. ¿Quieres que yo lea esta? O sea, que yo explique, o tú quieres hacerla?
Si quieres te explico, pero si me pierdo, me engaño.
Okay.
Hi, I'm Diana. But I it's not English good. So I'm going to try because yeah. So I'm going to try. But you can you so when that happened, one of coordinator of the shelter called us in the day and just like in crisis, no, for that woman that happened all that Karina told. And when we go up to the shelter, Etzel and I saw the kids and I work with the kids, and Etzel work with the adult woman. And
That was before hospitalization.
yeah, before the hospitalization. So, well, I work with both kids. The first kid with the 10 years old, it's a girl that it's a mini adult because their mom blind and have another kid. Well, the girl just like all the information that the mom, all the information that she and the another girl, and all the things that happened in the travel to go to TJ. So she told me that she saw one demon, no, in the nights, and she can't sleep, and the demon are more strong when mom go to the hospital, no? So that demon don't no la dejaba dormir. No la dejaba. Yeah, and that demon tells something, no? And this girl don't sleep, and all the shelter see the girl, no? Just like in the in the shelter don't sleep, and all the shelter like asking what happened. And when one family in the shelter have these things, all the shelter will worry and maybe have a crisis too. So it was difficult. So I work with she to describe the demon. Know what is the thing that happened with that demon, what is the specifically things that have these demons. So describe and draw and know about the characteristics and know the debilidades, weaknesses, and the strong part that it's inquieto y molesta en la noche, ¿no? There's a lot of energy que es muy inquieta. El demonio es inquieto. Oh, yeah. So when we draw that, we draw what is the things that we can do in the night for vencer a el demonio.
Things we can do.
Yeah. So she made rutinas para poder vencer al demonio. Yeah, a ritual.
Yeah.
Yeah, and we made it and we draw and we practice to do this in the night. And we have a lot of anclajes que platicamos el día de ayer. Como una ancla de barco. Yeah, to that she le daba seguridad. Yeah, and we practice in the day because she have a lot of energy to remember that and to have that ritual to the night. So she was so independent. So she really worked too good with that and to understand what she can do and what she don't can do, no? So that works for her, and to have a safe space with me, it was just a space to tell me everything for one moment, when people can know, like cargar todo, porque ella siempre cargaba todo.
Everything that she could.
Yeah, and the another day that she told me she sleep well. She can vencer al demonio con este ritual. Yeah. And she told me that it was a good fight and it was a good fight and she win. And the next slide is the girl for 4 years. This girl like esas sí son bien difíciles en inglés. Irritable. Bueno,
Yes.
can you help me to read this in English?
So she had like behavioral problems, like interacting with other young children inside the shelter. And then she had conflict with her older sister,
Yeah.
making decisions.
Yeah. So this girl just a lot of problems with the sister because you're not my mom. Why do you tell me that? No, like not going to listen to you. No, and she really have a lot of energy, a lot. All the shelter like can't support her because she's a lot of energy and don't listen nothing and broken things and all that stuff. Either the mom in crisis, either the another girl, no, in another crisis. So it was super difficult because it's just me and Edsel and all the shelter see us to like help me please, so it was hard. It was hard. And well, I have a relation with that girl and know that she needs attention and she really needs some people that support her and listen her and play but love her. No? So I work with her with that just a moment to stay with her and play, but I don't know, like apapacharla. No hay palabra, do not word for apapacharla, but yeah, maybe like yeah. But it's just in my time for work, no? It's just like in the night or 40 and a half, I'm going to leave. So what happened next? So the strategy for her, it was like finding a person in the shelter that have the same energy for her while mom in the hospital, you know? So some people have attention to eat for the time of eat or time to play or time to bañarse, have a bath. But the most important, some people who transmitir la calma. Yeah. And that calm super helps for her. Really have a change super fast. So, and that people help to have a mediation with the more adult girl, you know, the 10 years old, and really help while mom are in the hospital. That it was super hard, but both girls are really good, and I think that it's the most difficult when we are like working for kids, no, for that situation that you don't you can change like 1 hour, but you can change and you're gonna stay 24 hours for her. You know, you need to have a strategy to have that tools, even that you're not here. No, so that works for that family, and we have good news.
So,
Yeah.
So October 5th, the patient returned to the shelter after being a week in the hospital. I didn't really hear too much from the shelter after she came back. She ended up crossing 2 weeks later. She got her appointment. And I checked in with the staff recently, and it was probably been over a year since we treated her and her daughters. And according to the shelter staff, she found work giving massages at a spa, and her daughters are in school. And I don't know what her medications are, but we couldn't figure that out. But so far so good with that family, which is really nice to hear. We don't get a lot of follow-up. We don't really know what happens to our patients. It's very rare. Sometimes they lose their phones in detention and we lose contact with them. So it's a little bit tough. So it was really nice to hear that from the shelter staff. So Diana's going to talk about some retos, which are challenges that we experience basically that can be made apparent in working with this case. Huh?
can you read?
Okay. Oh my gosh.
Yeah.
So you're gonna talk about it or no? Okay. Okay, so just basically not having access to like psychiatry in Tijuana is like very difficult. We're the only free like psychiatry services in Tijuana. There's nowhere else. And so how difficult that was, basically we were the only ones that the staff was like kind of coming to. You can't really account on having the government for any kind of support with these types of cases. There are definitely people that are falling between the cracks. There's a big shortcoming in terms of like temporary like health insurance that can be afforded to migrants. There's another difficulty was like even within like there's not like a space para albergar las personas.
Salud mental en Tijuana gratuitos.
Yeah. So there's no way to hospitalize the patient for free. We'd have to like pay everything out of pocket basically. And so it's very rare for a shelter to find the funds to like hospitalize someone. We can do it if it's necessary. We have to like come together and vote if the case is severe, but it's usually when our resources were tapped out. And I was seeing that patient every day for like a while, but it wasn't like improving, at least in those circumstances. It might have improved in other circumstances. That might have been enough, but for the distress that it was maybe causing, I think it felt more it was distressing to everyone else like around her than it being actually like a dangerous situation. So it was kind of an interesting hospitalization to me, but she wanted to be hospitalized. So that's why she went willingly. What?
It's over $1,000.
So it's over $1,000.
But we'd have to pay for, like, think about that. You couldn't hospitalize the patient.
Yeah.
So you'd have to pay.
Yeah. I mean, it's necessary, it's necessary. I don't know that it was necessary, but they did it anyways. So it wasn't us, but and so kind of like I said before, we're the only one that has like volunteer psychiatrists. But now we have our lovely contracted psychiatrists who can help in their spare time too. And in this situation, if a mom was hospitalized, she had no support network, luckily, other than the shelter. And then Diana was able, because she's so charming, to like get people to like really buy in. And then maybe they were already buying in, because there's no way that a blind woman got from Haiti to Tijuana without having some real major skills. And I think it brings up this concept of disability, which is not, I think sometimes we have to like trust people who have disabilities. And I say that with quotation marks, because a lot of times it's just different abilities than what you're like used to and what you would expect is considered the norm. But really, this woman had a lot of capabilities, and she was able to bring people in to like help care about her. And she'd also navigated an incredibly difficult like journey with her 2 young girls, and she had made it not unscathed, but so is anyone who's considered typically abled. So I think sometimes we were like, oh my God, this poor vulnerable person. I'm like, she has a lot of strengths. We have to identify them to be able to like work with her. And that may have been part of why they rushed to hospitalize her too, in retrospect. But yeah, so I don't know if you guys have any like questions about any of that. I kind of just went through it. You know, we don't have a ton of time, but I thought it was a really interesting case and a great explanation of like, or just demonstration of how coordinated our efforts are and how shelters and our connections with shelters can really bring severe extreme cases to our attention, and where that leads sometimes, but where we really come up against significant barriers.
Español y en inglés. And the situation,
¿Lo quieres?
and the situation that we're the only organization que paga psiquiatras gratis.
Uno.
Okay.
Okay.
Uno. All the shelters, all the albergues, call us. Llama. It was so hard. Es difícil porque we should have. Okay, tengo que tener los dos. Which is hard. Es muy difícil porque we're going to 34 shelters now, approximately. Vamos a 34 albergues de Tijuana aproximadamente. And all the shelters have this confianza.
To trust.
Eso. Tienen esa confianza con nosotros. And call us, right? So, aunque no somos una organización de emergencia, even that we are not organization for emergency, they call us because we have that trust. No. Yeah.
Yeah.
Porque tenemos esa confianza con ellos, ¿no? Entonces, it's hard, but we have, a lot of people who love that work that really do that, right, for the people. Y tenemos gente tan increíble en la organización que hace esto posible, ¿no? Que la gente pueda llegar a tener este éxito en casos, aunque todo suena mal, ¿no? Even that the situation needs that.
I just want to say that even though we're an organization that the shelters or the community trusts, that's not always like, there's still like kind of like a negative aspect to that, because then that means that, yes, we're providing a stopgap, but it should be governmental organizations who we should be pushing to expand their services so that we are not just, it's not just falling on volunteers to do this. It's really the obligation of the people of, you know, of the government to really step up. And if we're keep filling up that gap, then maybe they will feel like they don't have to and they can step back. And so it's a difficult, so a big part of Refugee Health Alliance is our advocacy and our abolitionist like principles that really challenge infrastructural forces of oppression. Anyway.
Yeah, I think the time is
Yeah.
super late.
Yeah, sorry.
but I think that with that part it's done.
Mhm.
And I think that we explained a little bit how we work. Yes, es lo que corta. Para el tiempo, ¿no? Como una manera de explicarles cómo trabajamos en RHA. So, yeah, big aplauso. Buenas noches. Buenas noches.
Yo voy nada más a presentar brevemente en unos
I'm just going
4
to present
minutitos.
briefly in a few minutes.
Si puedo mantener su atención 4 minutitos más.
If I can keep your
Sobre
attention for 4
todo,
more minutes,
como algunas...
I'm going to.
voy a cambiar de idioma. Just like a few concepts or things to reflect when we live today. So in this image, we can see some of the things, elements that we need to maintain good mental health. It's of course not all of the things we might need, but some that are very important. We need like a safe space, and we need, as we talked earlier from our first days, carers that can provide safety also, and that can provide good parenting, respectful parenting. And for that, these carers need to have available time, which most don't, because either they're working full time or they're here at the shelters. Also, they have other responsibilities to take care of the shelters, because as Karina said, many of these places, and as you've seen, are self-maintained by the people who are there. We also need physical safety also, which, for example, here in Mexico for migrants is not provided by security people, by the police, by the military, etc. We also need a quality education, space and time for recreation. There's, I don't know if you've seen, it's difficult here in the places we've moved around to see, I don't know, like parks and spaces for children and for teenagers and adults to have this space for recreation. We also need health services, which we've talked about are really difficult to access. So I wanted to talk a little bit about who has and why some people has and why some people don't have access to this. So just thinking about how privilege is this systemic form of advantage that some people have because of the different systems or like social categories they are assigned by social constructs, and that are and how different people are, we say in Spanish, atravesados by different systems of oppression that intertwine ones with others. The ones who have been granted these like hierarchies, social hierarchies, have these privileges, and they usually they are perceived as something that is deserved and natural or won like through effort. And those who don't have it are perceived to not having it because they have like a moral failure or a character failure, or are not like capable enough to have them. And this is not true, as we've seen. Having granted these like different social categories and being atravesados by these different systems of oppression manifests in different health outcomes and social outcomes also, and in different opportunities to have all of these things we need to maintain or have our mental health back. We've already talked a bit about different social determinants of health, and so the 4 minutes are over. And in this image, we can see different layers of power and privilege, depending on, for example, gender or income or the shape and size or type of body, and of course, racialized skin color or other characteristics, but also the other structures that are like the governmental policies or politics and the economic system in the specific country where a person is, but also the global economic system, and how these decisions actually can hurt people directly. And with this, I wanted to talk also about, well, these structures cause harm directly, but also the political decisions that are made at a certain point can also cause direct harm. And this is like a tweet that Donald Trump made in 2020, telling that there was this like attack of the invisible enemy, and that he needed to protect American jobs, so he was going to suspend immigration. And different reasons have been told throughout history to reinforce these border policies. And the other thing I wanted to say is that also health institutions, and as Karina was saying many times, public health institutions can increase the suffering of migrant people and people in mobility. For example, if this case we were talking about, if this woman would have gotten to a psychiatric hospital in Mexico City from the government, which would have to provide emergency services for free according to the national health law, it is probably that she would have faced an administrative staff person who has the order to restrict access to people who doesn't have a national identity card with photography, or because she doesn't have another adult family member accompanying her who can take care of her or the kids. So even if there were a public hospital, she wouldn't have gotten the care that she needed. And well, this is the expert of the national health law. So just like to stay with this phrase, like if health is a human right in Mexico, in our constitution and in our health law, it is a human right, then who is considered human enough to have that right, and why? Who decides and why is that? So
so if you haven't looked yet, I'd encourage you to look inside your folders. There's a lot of great stuff in there that someone donated that paper to. Okay, maybe my husband printed it at work so that I can make sure you all get some copies of things. Great points about psychological liberation, right?
So one of the big ones I just want to say is that when migrants cross into the US, they really, really struggle finding resources. And so this is a flyer I want you to know. If you don't have Find Hello on your phones, I recommend downloading it. It's a really good app that helps people with finding those apps, the services they need. The flyer should be in your folders as well. I just have so many cases that I've worked with in TJ, and they're like, oh yeah, I got across, great. And then like they contact me so many months later and they're like, oh man, I'm having so many problems. Like, what? You didn't get connected with mental health yet. You haven't got connected with job yet. You haven't connected with all these things, right? Just like Sean was saying, there's a few percentage of people do cross. Even then they don't get like what they need. And what he was mentioning earlier about the asylum eval can't be emphasized enough. So for all our Mexican staff who go and work on this side of the border, talk to people beforehand. As soon as you cross into the US, very second you get there, have them go to the Physicians for Human Rights website to get their pro bono lawyer. This is a really big thing because these asylum evals take forever. Their court dates come for a long time. And so we're just delaying their suffering. So I just want to be really clear. If anything, I hope that this conference also increases the awareness of coordination of care across the border because this is a huge problem that we have. And for those on the Mexico side, you can tell people about 988. That's our crisis number. On the US side to give out to people. Kind of complicated to explain. Our health system too is broken in many ways as well. But you can just tell them to at least call those two numbers that I mentioned. 211 is our informational resource. And there's fighting financial resources. Migrant Clinician Network is also a really good thing if you haven't heard of for connecting people with services. So as we've talked about today, resources are just really limited, right? It's really depressing how bad it is. So, I understand we're all working to our limits, but I hope at a minimum you can all consider sharing about what you heard here today. Get your phones out. I know social media, some of you are on there somehow. If you don't have social media, text your friend about all the things. This is our link tree. It has a lot of the websites for the video, and all the links are on that colorful blue yellow sheet in your folders to share with all your homies. I just want to also emphasize how important it is to also recognize what a difference we have in resources. Like with this case that they were sharing, even the mom being blind, who knows, maybe if there were some more better preventative services or other things, maybe she wouldn't have gotten to that point. So here's an example. We had this situation happen. These are just some texts from it where somebody needed to call 911. I have had to call 911 in the US for stuff not in my work, and got there in 2 minutes. In Mexico, we tried 99 minutes. It's more than Mexico City. I know, it's more than Mexico City. And so it's really bad in TJ. This person was in a domestic violence situation. We did some things to try to help her, but she thought that the man was going to kill her and her baby, right? So just that's, I think, a good reminder of how low the resources are here. After 6 calls, it's a translation. So I really hope that helps you think about the importance of connecting people with resources. We just had a whole situation with child welfare services here in Mexico trying to help this child who's Munchausen's by proxy. And it was a kind of a complicated case. Apparently, we tried to show up to child welfare, explain the situation, and they kind of laughed at our stuff. And it's just ridiculous. And I called my friend in the US. I was like, is there anything we can do? Or we don't even know if it's her kid, or she just where this kid came from. She was like, nah. And so I think sometimes we think especially on the San Diego side, we'll say, well, this is Mexico's beef, right? Mexico child welfare responsibility, but it's just a mess here. You can't trust them to do much. And I think it's worse than Mexico City too. So I just want to emphasize how low the resources are here. So given that, I hope that you can think about donating to RHA. When you think about it, if you have someone in private practice, or if you just know your friends, a lot of us therapists, we're burnt out. We don't want to push yourselves more. But if you just have 4 therapist friends, I don't know, I think the psychiatrists make more than us therapists, to be honest. But if you have 4 friends, they make $125 an hour, 4 of them in 1 month. That's enough to practically cover one therapist here's full month of salary, right? The work you did here, half a day, if you just did work there in the US and you donated that much money to our staff here, I could hire a whole nother psychologist if you donated once a month. So I want you to really think about that. I understand that it's hard to come here and maybe some people don't feel as comfortable, but at a minimum, you can try to balance out that privilege that we have with that kind of way, if you want. I also understand we all have other demands. So at the minimum, just tell other friends about it and think about those resources. So yeah, there's a fun monthly payment option, so you don't have to think about it. And just so you know, we do have opportunities for psychiatrists for work and volunteer. We have a lot of volunteer 1 hour a week psychiatrists who do this work. And there's a flyer in there. So if you know any Mexican psychiatrists, please share that flyer. And then we also have a ton of other volunteer options. I know today's was a funky one on Volunteer Hub, but this is where you sign up. There's links for it. And then I just hope at the minimum, we do an Instagram photo all together. So we'll do a photo in a moment. And then you're going to all be like, put your fun messages about Instagram. I don't know. I'm too tired to think of fun ones, I guess. And I just want to say thank you so much for everyone. San Diego ACAP, thank you so much. Really appreciate it. Wouldn't have done this if we hadn't got the grant, for sure. At me, muchas gracias. La verdad, te admiro mucho y hiciste tantísimo. Nuestros empleados que están limpiando, que no pueden escuchar, que ayudan. Thank you for our workers. OIM Aves Displaced, Espacio Migrante, who donated all those headsets to help us all speak together. Oh my gosh, the food's been so good. That's these guys. Caricias. Airlinks helped with some of our flights. And then we have some other volunteer interpreters. Ustedes, gracias, the interpreters back there. All of you. And then I have to put out there, I don't think we could have done this without our partners and our social support. I got to meet Diana's lovely partner. My husband helped with me and food and dinner this week, right? We can't do this without our partners, gracias. I just think we have to also appreciate them. So please tell your partners, I said thank you for letting you come here and watching your kids today. So thank you, everyone. We really appreciate it. I hope you can convert do the eval for them.